once in their lifetime, and 5% of them continue to have this back pain throughout their life, and they keep visiting doctors multiple times. And one common reason why the back pain happens is the disc disease. So it is a very important topic that needs attention, and the correct learning of which would give us the right way to approach it. And to deliver the knowledge to all of us, we have Dr. Ramakrishna Easwaran, the director of Neuro Hospital, Trichy, consultant neurosurgeon. He did his MCH.
But you work on the I got disconnected.
Yes, fine.
He did his MCH in Nimhans, Bangalore in 1988. He was the best outgoing student and a medal winner. He was an assistant professor in neurosurgery in St. John's Medical College from 1988 to 1990. He started his private practice in Trichy and he's been practicing there for 34 years. He has 8 publications. He's written 20 textbooks. He's addressed various CMEs, and he has tutorials made on CDs. Professor Natarajan Gold Medal for Neurospinal Surgery Foundation of India 2002, and Abdul Kalam Award, St. Joseph College, Trichy in 2016. He also delivered the Professor B. Ramamurthy Oration Award in 2017. He has received the Lifetime Achievement Award of Tamil Nadu Association of Neurosurgeons, and he loves Carnatic classical music, writing and composing. So we have an all-round personality and someone who has years of experience in handling backaches to talk to us and teach us about lumbar disc disease. Over to you, sir.
Thank you, Dr. Hariharan. Thank you, Ramakrishna. Thank you, Hariharan.
Thank you, Dr. Ashraf, for having recommended my name to this august body, which is doing such a good work on spreading the knowledge about the modern state of art of medicine and surgery to the doctors of Tamil Nadu. My pranams to all the office bearers, and especially my thanks to Dr.V.Aruljothi, who's doing an excellent job of conducting these meetings. Thank you, Dr. Hariharan. So I will, as you all have said.
Sir, can you please share the screen?
This, but also we as doctors. Yeah, I'll do that. I'll do that in a minute.
No, please mute everyone. Please mute everyone.
Please. We ourselves, most of the time, we are sedentary, and because we are sedentary, we are more prone for this kind of disc prolapse and such other back problems. So I'll share my screen now. Are you all able to see the screen?
Yes, sir. Clear, sir.
Clear. Okay. So it's a very short period of time, about 30-35 minutes, in which I have to give an overall view of the lumbar disc prolapse as it stands today. So let me start my topic right away without wasting much time.
Hello.
Now, you all know that it's becoming a very important problem because of the life changes that have occurred. See, my grandfather used to walk every day 3 kilometers to take his bath in the morning to the river. But nowadays, we walk hardly 2 steps from the bed to the bathroom. So our physical activities have come down. We have become couch potatoes. And you see, in 1980, the computers were large. The man was small. Now the computers have become very small, even available on a phone. And the man has become really huge and fat. A lot of bad postures during work. And after working like this for 5 days a week, on the weekends, the youngsters go for such kind of holidays that really strain their back. And if you take the poorer section of the society, they have to manage like this on scooters. And the problem starts very young because of the carrying of the big back loads by children. And of course, women do a lot of physical work, carry a lot of weights. Same thing with people who are in the jobs like porters, etc. So you find that across the spectrum of whether it's in a very rich society or in a very poor society, you find that backache is a universal problem. It is so ubiquitous that the new episode incidence is about 6 to 15 every year. The point prevalence, that means if you are in a city with a, let's say, 10 lakh population, nearly 1.8 lakh people, in that 18% of them will have backache. And in 1 year, at least 3.8 lakhs will develop pain. Some of them will disappear. Some of them will continue to have pain. The prevalence has been rising over the years. Every decade, you find that there is an increase in the incidence of the prevalence of backache. And I have looked at my own patient data, and I find that majority of them come from general practitioners and from the neurologists, some from the orthopedic surgeons, some from the gynecological surgeons. Many patients come on their own, and some are referred by people who are not in the medical field at all, like, for example, yoga practitioners or sometimes physiatrists and such other people. So you see patients with backache go to all sorts of specialists or general practitioners because their problem, they are not sure what their problem exactly is. And if you look at all the operations I have done, nearly 27% of them are in the lumbar spine. 26% of them are in the brain, and 27% of them are in the lumbar spine. So it is such a common problem. Now, if you look at the pathology starts off at a fairly young age when there is a chemical degeneration inside the disc. But at that time, it's not symptomatic. It becomes symptomatic once there is an annular tear. The annulus of the disc ruptures. And then there is sometimes a bulge of the annulus, which is the next stage. And then there is compression of the nerve roots. Then there is progressive narrowing of the space for the nerve roots by bony hypertrophy, facet hypertrophy, or ligamental hypertrophy. And finally, there is a degenerative instability. And all these have their clinical correlates. In the acute stage, they present with acute back strain. Then they develop recurrent backache and sciatica. Then some of them go on to have persistent back pain and leg pain. Some of them develop claudication. And finally, they develop instability pain. So the pathology and the clinical spectrum are very variable. You can get the patients in any of these spectrums of pathology and clinical presentations. Now, if you come to the etiology, in fact, I have written the textbook chapter on etiology of the disc prolapse, whatever research that has been done. But ultimately, when the patient comes to us and asks me, "Doctor, why did I get the disc?" we still are not sure why the person has got the disc. Most of the time, we blame it on mechanical factors. Like, for example, people are saying about car travel, etc. That alone is not the problem. The problem is it has to act along with all the other things. There must be a genetic predisposition. There must be a factor of vascular and aging. There must be a mechanical factor that it's just acting as the last straw that broke the camel's back. That means there has already been an underlying genetic predisposition. Biochemical inflammatory changes have already occurred in the disc. There is some vascular ischemia in the disc. With all these things, when the mechanical trauma also happens, it becomes a full-blown clinical syndrome. So it is an interplay of several factors. So for a particular patient, we cannot say that this is the cause for the disc collapse. And just today, I saw a patient whom I had operated last week. She has come back with a good relief of pain. And she said, "My son got relief in 1 day. I got relief in 1 week. What is the difference, doctor?" What it means is that there is some kind of a genetic predisposition in that family. So this chapter is in the textbook has been written by me. And anybody who's interested can go through this Ramamurthy and Tandon's textbook for all the details of the etiology. Now, our business as clinicians is to make a clinical diagnosis. And in orthopedics, the Apley's textbook always says for fractures, look, feel, move, and X-ray. There are 4 stages in making a diagnosis. But for neurological systems like the back, my own recommendation is listen, watch, examine. And don't touch that MRI till you have finished all these things. The problem nowadays is most of the patients come to us with an MRI already taken. The MRI is already reported. The patient already believes what is there in the MRI as the truth. So we have to really listen to the patient to come to a conclusion as to what is the problem. Watch the patient as he walks in, as she sits, as they go and lie down. All these things give us very valuable clinical information. And then we examine the patient to make sure what are the clinical signs that are there in the patient, what is really troubling the patient. So only after we finish all this, we look at the MRI. Otherwise, you are likely to get very biased about what you're going to see in the patient. So these are all the various ways in which patients have come to me. They've come leaning like the Tower of Pisa. like this because of this is called as sciatic scoliosis. Some people just cannot erect their trunk, and some people come in so much pain that they come on a wheelchair, they can't even stand, or sometimes they are even brought on stretchers. This man was not able to get relief in any position other than this. He had a disc prolapse like this, and this man was always sitting like this to get a relief of pain. And this is the disc prolapse that you see in these patients. So various kinds of, these are all things which you can just observe as the patient comes into the clinic. Of course, we do have these pro formas. These are useful for research purpose. They may not be really useful for day-to-day clinical practice, but these are the things that you should look at really. What is the location of the pain? Is it back pain? Is it leg pain? What is the nature of the pain? What is the location of the pain? Where is it actually traveling from where to where? What is the duration of this pain? What are the mode of onset? What are the precipitating factor? This is applicable to pains anywhere in the body, and much more so for the back, because in most patients with lumbar disc prolapse, you will find that there are hardly any clinical neurological signs, except maybe a little bit of restriction of the straight leg raising, and not much of other signs. So it is a history that really gives you the diagnosis in these patients. So examination either confirms, refutes, or modifies the diagnosis made by analysis of the history. We look at the back for the curvature. You can see this is a sciatic scoliosis, and that is a step in the back. You can feel it here actually. If you run your finger along in this region, you will see that there is a step in the back which tells you that there is a spondylolisthesis. Vertebra has moved in front of the other. And then you'll see the spasm of the muscles, and then the tilt maybe to this side or to the opposite side, depending upon where the disc prolapse is located. And then we do the neurological examination. In that, main thing that we look for is a straight leg raising test, which is done like this without bending the knee. The reverse of it is the reverse SLR or crossed SLRT, which is the opposite side. When you lift the left leg, they get pain in the right leg. That is called crossed SLR. You also look for weakness in specific muscles, not the entire, all the muscles that are there in the lower limb. It's too difficult to examine all the muscles. Just examine those important muscles which are normally lost in disc prolapse. Similarly, sensory loss, reflexes. You watch the gait of the patient, ask the patient to walk on her heels, walk on her toes, and then hop on one leg. And then if there are no clinical signs at all, you can make them walk about for 10 to 15 minutes, ask them to come back and immediately re-examine them. You may be able to find a neurological deficit in patients with claudication. So we must remember that the level of the disc and the root is very important to remember. If it is the L5 root, it crosses the L4-5 disc and then goes under the pedicle of the L5. And therefore, in a disc prolapse that is located over here at L4-5 level, the L5 root will be involved. Okay. And similarly, for a L5-S1 disc, normally the S1 disc is involved. The second number of the what is there in the disc's number. Okay. But this may not be so if the disc is up migrated. If it is up migrated like this, it will go and press on the root above here. And then it causes L5 symptoms. So from clinical examination, you can infer that it is the L5 root that is involved, or S1 root that is involved, or L4 root that is involved. But you cannot say which is the disc that is prolapsed. For that, you need radiology. So these are the typical locations of the pain, numbness, the types of muscles that are weak, and what are the jerks that are involved in the common disc prolapses, which involve the L4, L5, or S1 roots. You can also have rarer disc prolapses at higher levels like L1, 2, L2, 3. They are not very common. L4, 5 is the commonest. L5, S1 is the next common. L3, 4 is the next common. So these are the muscles that you need to really check. You just need to check the extensor hallucis longus, foot plantar flexors, which can be done by your toe walking test, and the tibialis anterior, which can be done by the heel walking test. It's also important to do a good orthopedic examination. Even if you're a neurologist or a neurosurgeon, you should know to do orthopedic examination, because many of these pains overlap, and sometimes they may have more than one disease. A person with a lumbar disc prolapse may also have osteoarthritis. A person with lumbar disc prolapse may also have diabetic neuropathy. Therefore, we must be able to completely examine all the systems that can cause back pain and leg pain. So these are the tests for the knee joint, hip joint, and the sacral leg joint. These are things that we now routinely do in a clinical examination. Sorry. So at the end of your history and examination, you'll be able to say what exactly this patient has got. It may be just a backache, which is called lumbago. Remember, lumbago is not a diagnosis. It is only a label. It's a label given for the syndrome. There may be hundreds of causes of lumbago, but you identify the syndrome as lumbago. Similarly, sciatica. A lot of patients say, I have been diagnosed with sciatica. Sciatica is never a diagnosis. It is just a clinical syndrome. It's not the complete diagnosis. It's not the cause of the disease. Sciatica is the name of the disease. radiculopathy, which means there are neurological deficits. Sometimes it is just a neurogenic claudication, pain that is brought on by walking or standing, and the pain gets completely relieved on sitting or lying down. And sometimes they may get involvement of the bladder, bowel, and bilateral symptoms, which is the cauda-equina syndrome. So these are the 4 basic syndromes that you will identify at the end of the clinical history and examination. You may sometimes have a problem in an elderly person who has got diabetes, who's got atherosclerosis, or who may have thromboangiitis obliterans. How to distinguish between the ischemic and vascular claudication. So this is a table that tells you the pain is in the gluteal region, leg region, neurovascular in neurogenic claudication, whereas it is in the calf and foot in vascular claudication. The nature of the pain is different. What causes the pain? Standing erect can cause pain. Standing never causes pain in a vascular ischemia. Only walking causes pain. And it is relieved by sitting, whereas this is not relieved by sitting. It is relieved sometimes even just on standing. The associated symptoms, neurological symptoms may be there, or here vascular symptoms may be there. And they stand in this kind of posture, neurogenic claudication patient, because when you bend your trunk forward slightly, like how you do when you push a shopping cart, there is a slight expansion of the canal. So the symptoms become a little less. Similarly, when you, after the walk test, you may have some soft neurological signs like a sensory loss or a reflex diminished. You can also do, if you have a exercise bicycle in your physiotherapy department, you can ask them to do a bicycle. And the person with neurogenic claudication will never have pain on cycling. In fact, many patients who have got diabetes, a 70-year-old man, he comes to you with pain in the legs, which is brought on by walking due to neurogenic intermittent claudication. He doesn't have any other symptom, just this neurogenic intermittent claudication after walking for 20 minutes. You just ask him to switch over to cycling as a method of exercise, his pain completely disappears. Whereas cycling causes severe pain in ischemic claudication. So now we have identified the syndrome. Now we have to find out what is the etiology. This is a matter of guesswork. And sometimes you have very common diseases. It is said in English often that when you hear hoof beats, it may either be horse or rarely it may be even a zebra. So the horses are the common condition, zebras are the rare conditions. So let us see what are these. If the patient has been having pain only for less than 3 weeks, it's called as acute pain syndrome. And for this, the common causes are back strain, compression fracture, and disc prolapse. Whereas the rarer causes are epidural abscess, pyelonephritis, and aortic dissection. The subacute, that is 3 weeks to 3 months, the common causes are disc prolapse, tuberculosis of the spine, and neural tumors. Neural tumors typically cause pain more at night when they're lying down. Disc pain is never more at night. It's usually much less at night. And the rarer causes will be bone tumors and pelvic causes. See, there are also other things, not just all neurology. There are other conditions also, like aortic dissection, pyelonephritis. All of them can present with acute back pain. And in chronic cases, it's usually spondylosis, canal stenosis, or mechanical low backache. Sometimes it is just a depressive neurosis or malingering. Whereas more serious causes are spondylolisthesis, ankylosing spondylitis, osteomalacia, fluorosis, ochronosis. So this is a list that you should remember in your mind and try to exclude these possibilities one after the other, depending on the clinical presentation. To have a short list is always better because this covers about 95% of all the diseases that cause your back pain. So if you just remember these three conditions in each of these, so 9 plus 9, 18 conditions, you will have ruled out almost every single cause of the back's problem and zeroed in on one particular problem. Now, what happens to these patients who come to you with a backache? Dr. Hariharan mentioned right in the beginning, some of these patients, the lucky ones, they have only one episode of backache, they become better, and they never have backache again. Whereas in many other patients, it becomes a recurrent problem, keeps on coming back again and again. And in a few others, almost 40%, it becomes a chronic problem. That is why it's important to diagnose the problem when it is in the initial stages and treat it and prevent it from going on to the chronic stage. Now, when you see the patient, you should always be aware of some red flags. What do I mean by red flags? Those conditions that raise your suspicion that there may be some serious disorder underneath. Usually at extremes of age, very young children, very old people, they usually have some kind of pathology. Young children usually have infective pathology, whereas old people have malignancies as the cause of the back pain. Progressive rapid worsening. Patient is walking yesterday, today he's not able to walk. That means there is definitely some significant degree of compression that is there. Patients with nocturnal pain usually have tumors, and patient who has early sphincter symptom, that is inability to avoid urine, they also need to be treated urgently. A patient who's got fever or weight loss might either have an infective illness or a malignant illness. So these are the things that sets you thinking about more serious causes of back pain. Now, I look at my patients in a very simplistic manner. Persons who come with low back pain, I classify them just into two groups. Those who have got neurological signs, those who do not have neurological signs. If they don't have neurological signs, very likely that they have only some self-limiting cause for back pain. You can afford to treat them without any investigation conservatively for some time. What is the period of some time? I think about 2 weeks. Within 2 weeks, if they don't get better, if they are same or worse, or if they get a recurrent pain, you have to go back to the other arm. If they become better, then you just teach them back care, keep following them up, tell them how to prevent more episodes of back pain. Whereas if they have neurological signs, you don't hesitate, you wait, you don't wait for a longer period of time, you get the MRI done straight away and then decide on what is the problem and go for appropriate treatment. So this is a very simple looking decision tree, but not following this causes a lot of problem. There are two things that happen. One is a patient who really needs an MRI does not get the MRI done. And sometimes a patient who does not need the MRI at all gets the MRI done and becomes neurotic about it because no MRI of a person who's more than 20, 25 years old will be normal. It will always be reported as abnormal. It will show some kind of disc bulge or something, some change will be there at some level. And then the patient keeps on getting worried about this all his life. And that sort of thing should not be allowed to happen. So that is why you need to bear this very simple decision tree in your mind. So when do I get an MRI done? When there's an acute severe back or leg pain, which is limiting all the activities. When there is recurrent pain that causes a limitation in your daily life. Pain persists despite a course of conservative treatment for 2 weeks. Or when there is a neurological deficit, or when one of those clinical red flags I mentioned to you is there, I should immediately get an MRI done. And you can avoid getting an MRI done if it's a very mild self-limiting pain or non-disabling back pain, a pain that is resolved. Many patients come and tell me, I had this pain in October, sir, but now I don't have any pain. Should I get an MRI done? I say, please don't get an MRI done. If you get an MRI done, you go mad. And when claudication happens only with unusual activity, there was one patient who told me, he's a 65-year-old man, after retirement, every Purnami, he goes on a Girivalam to Tiruvannamalai. And when he does that, only he gets pain. He doesn't do it on rest of the days. Rest of the days, he has no symptoms at all. So all that he has to do is he has to walk slowly, or he has to try to make a shorter Girivalam route or something of that kind, right? And when the patient has got just a very small sign, like for example, an absent ankle jerk, pain syndromes, patients with claustrophobia, they usually become worse after MRI because they're so frightened to get MRI done. And you cannot get MRI done when there is a cardiac pacemaker, when there is a neurostimulator or some of these other electronic implants inside your body. Now, why do I say about this MRI so much? Because once a label is cast on the patient, once somebody says you've got a disc prolapse, that patient takes it to be the gospel truth. And in the small letters, it is written in the bottom of every report. Radiologists really truly mean it when they write that this is not to be taken literally, it has to be taken along with the clinical signs. But nobody heeds that disclaimer. If it is there in the MRI, it is there in you. That is what they assume. Asymptomatic MRI findings do not predict future course, and that is why I don't get MRI done unnecessarily. This is an example of a patient who had a very mild fall, minimal backache after the fall. Able to get up and walk about immediately after the fall. That patient was diagnosed to have a small sacral cyst here. Incidental finding on MRI of no clinical relevance. I think this lady consulted at least 10 neurosurgeons, and of them 8 recommended surgery for this. I did not operate on her. She is still on follow-up with me for 10 years, and I have just given her confidence. And every 1 year she comes and asks, sir, has my cyst grown bigger? I say, no, nothing has happened. Don't worry. You are perfectly normal. So this is a job that I have to do in the OPD most of the time, to comfort patients, saying that they need not worry about their MRI findings. And this has been proved by studies also. When you have a study was done of 67 totally asymptomatic persons, 31%, nearly 1/3 of them have an MRI abnormality. They were followed up for 7 years. 58%, that is vast majority of them, still remain asymptomatic. Even in those who developed symptoms, there was no correlation between the side or site of the abnormality seen in the first MRI and the subsequent symptom that developed. So similarly, you will find that these MRI abnormalities may take many forms. They may take in totally asymptomatic persons. You may have disc bulges, you may have protrusions, you may have extrusions, You may have annular tear, facet degeneration, small nodules, all sorts of pathologies can be there. And in nearly 1/3 to 2/3 may have abnormality, which is totally asymptomatic, which is something that we need not worry about at all. So this is a look of the normal MRI. It's called T2 weighted image. The CSF looks white in this. The water in the nucleus pulposus also looks white in this image. And this is the canal. You can see the roots here. There is no compression from the facets. This is a normal kind of picture that you should expect to see. But this is not commonly seen because most patients have some change or the other. This is a T1 weighted image in which the CSF looks dark. And these are the two images which you need to compare to see whether it's an acute or a chronic problem in the spine. And when you read the lumbar spine, you must always make sure that your levels are correct. This patient came to me with a report of L4-5 spondylolisthesis and disc prolapse. That's how it looks. This looks like S1 body. This looks like L5. And this looks like the L4. So it looks like L4-5. This patient did not have, even in the present day, many centers do not do a whole spine screening image. But that is absolutely vital for this. You see what happened when I got the whole spine screening done, counting from C1, C2 like this all the way down. This turns out to be actually L5. This vertebra which looked like L5, S1, actually turns out to be L5. So this disc prolapse is actually at L3-4 level. It doesn't really matter much what you call it. We are going to operate on this level because we are going to look at this level on the C arm, and we are going to operate on this. But we would have called it by the wrong name. And if somebody gets a whole spine MRI done, then there will be a confusion between what you have written in your summary. You would have written that you have done L4-5, whereas actually the problem is at L3-4, right? Similarly, you can also have what is called as lumbarization of S1. L5 is here, S1 is here. So S1-2 is the last disc, not L5 S1 disc. And sometimes you have patients with multiple abnormalities in which it's difficult to say which is actually is the level. Here there are some fused vertebrae here. There are some combined vertebrae. So sometimes it's difficult to make out these levels in spite of a full spine MRI. You can see that this disc has got water. This has no water here. It's become dark. It's dehydrated. This is the earliest stage. There's no bulge over here. Then you get these subannular hyperintense zones, these small little semi-lunar white things that you see in the T2 weighted image. And then there is a loss of disc height. There are changes that occur in the vertebral body by the side. All these are degenerative changes. These should not be mistaken for an infection. There may be, when there's more than 50% of the surface of the disc is involved, it's called a bulge. And when there is a protrusion, the base is much bigger than the apex. And when there is an extrusion, the apex is much bigger than the base. There's a narrow base and a big apex over here. And this is called as extrusion. These are the various stages of disc prolapse. And depending on the location, it can be either central, paracentral, foraminal, or lateral. So any of these things can be there. And in relation to the nerve, it can be either a normal situation. There is a disc prolapse over here, but the nerve root is not displaced. It is not touched. It is not compressed. This kind of disc prolapse you need not worry about. That is the example here. And then you have another example over here where there is just contact. This may cause symptoms by mechanical irritation as well as by chemical irritation. And then there is a displacement. This definitely causes symptoms, especially during movement, during coughing, etc., where there is a little more compression. And then finally, you have compression, in which there is a static symptom, constant symptom that is there in these patients with reference to this particular route. So these are the stages of disc prolapse: degeneration, prolapse, extrusion, sequestration. And you can see the examples over here contain protrusions. And then the protrusion comes under the ligament and stays here on the body. And sometimes it comes out of the ligament and it migrates inferiorly. Sometimes it migrates superiorly. So all these kind of phenomenon can be seen on the MRI. And the MRI has made our life so simple compared to the days when we used to do CT and myelography, etc. And this is a sequestered disc. You can see the whole disc is lying inside the canal over here. These are the roots that are pushed badly towards one side. This patient had cauda equina syndrome, and that is the size of the single mass that was removed free from the spinal canal in this patient. Okay. Sometimes the disc is not inside the canal at all. It's outside and it's pressing on the root that is going out over here. It's called a lateral disc, far lateral disc. This needs to be recognized because it needs to be treated differently. It cannot be treated just like the normal disc prolapse. Sometimes you may get symptoms of the opposite side also. This patient has got right side sciatica, right side straight leg raising is restricted, left side is perfectly normal, but the whole disc prolapses towards this side. This is something like a contre-coup phenomenon. Like, for example, you get hit on the right side of the head, the left temporal lobe starts swelling, opposite side. So similarly, you can get contralateral symptoms. This is a phenomenon that you need to contend with. And everything depends also on the size of the canal with which they are born. All of us are not born of the same height, same weight, etc. We all are very variable. Our size of the spinal canals are also variable. And this person has got a very large prolapse, but hardly any symptoms, just an occasional back pain, that's all. Whereas this patient has got a severe sciatica, there is restriction of straight leg raising, there is weakness of the foot dorsiflexors, because the canal size is very small in her. This prolapse is not so big as this, but the canal size is very small, and therefore the patient on the right had a lot of symptoms. You can correlate these symptoms to the MRI findings. This is a weightlifter who had 5 days of low back ache after lifting a heavy weight. He has also got sciatica, and this is an acute protrusion. You can see that water content is still there inside the disc. It is looking white here. Whereas this is a lady who had 3 years of low back pain. That means there's already an ongoing degeneration, already ongoing symptoms due to the disc bulge. And suddenly she develops foot drop for the last 12 days. This is an acute protrusion that has occurred over here on a chronically degenerated disc. This has no water content at all. And this patient has got 5 years of low back ache. There's no sciatica, and this is just a degenerated disc. These are the patients in whom you will not just do a discectomy. You may have to do something more than just a discectomy in these patients. I'll also show you some examples of such patients later. And this was a patient who had backache for long. His profession involves carrying a lot of heavy can of pesticides on his back. He had sudden painless weakness of both legs, urinary retention, constipation for 3 days, and there is dense sensory motor loss in L5 to S3 segments. He's not able to walk. He's got a huge sequestrated disc over here, and this is a disc that is chronically degenerated, and now it's become sequestrated. Sometimes you may get symptoms not from the disc itself, but from degeneration of the synovial joints, which closely mimics a disc collapse, the same kind of root compression from the synovial cyst that is seen in the MRI so beautifully. And peculiarly, there are some patients who refused to have surgery. This patient refused to have surgery in spite of the fact that she was very symptomatic and had very large disc prolapse. We recommended surgery strongly because we thought she would get very good benefit. She just managed with the chronic pain for about 6 months. She became better, and she came to us about 1.5 years later. And I did an MRI again just to because I was curious to know how she got relief of symptoms. You can see that this big disc collapse has completely disappeared over here. What has happened? Once the disc comes out, it loses its nutrient cycle. It gets its nutrition from the vertebral body above and body below. So this part becomes dried out over a period of time. And then the macrophages eat up this part of the disc, and it just completely vanishes. But this is not something on which you can bet. You cannot predict and say, okay, this patient's disc prolapse may get better on its own. So the ideal thing would be to operate on these patients with such large prolapses and neurological deficits and symptoms, and not wait for spontaneous resolution, because this happens in 1 in 10,000 cases. So remaining 9,999 cases, this will not happen. But it is a phenomenon that is known to happen. That is why I have recorded it and I have shown you. CT has got not much role. It is used only in patients to check for calcification on the disc margins or ossified posterior longitudinal ligaments, and what is seen as vacuum sign. We usually do it for patients in whom we do vertebral fixation because we want to know their pedicle anatomy. We want to know to be able to do pedicle screw fixation. For them, we do the CT. CT otherwise has no role. If a patient has got backache and leg pain, please get MRI done, not a CT done, just because the CT is available with you. Now, coming to the treatment part, there are various choices that are available for treatment, right from bed rest to manipulation to various forms of injection therapies, percutaneous discectomies, microscopic discectomies, and then placing pedicle screws and fixing them. The whole variety of treatments are available. So you need to be informed about all of these so that you can make the right decision for your patient. Generally, what happens is we become expert in one particular method of treatment. Like a person, an orthopedic surgeon who does only conservative treatment, he thinks conservative treatment will solve all problems of disc prolapse. But that is not so. This is called as Procrustean bed approach. Procrustes was a Greek mythological person who used to ask his guests to lie down on a particular bed of a particular size. If they were longer, he would just chop them off at the legs or head to fit the size of the bed. If they are short, he would stretch them to fit the bed. So we should not fit our patients to the method of treatment that we know. Instead, like in a restaurant, when you go there, the waiter offers you a choice. He gives you a choice of things. These are other things that are available in the restaurant. And the customer makes a choice out of the choices that are available, and whichever is suitable to him, whichever fits his pocket, whichever appeals to him, he makes that kind of a decision. This is called as the eclectic approach. So, and how do you make these good decisions? These good decisions will come from experience. And how do you get experience? Experience comes from making the bad decisions. That's what somebody said. And experience is merely the name that men give to their mistakes. And that's what Oscar Wilde said. So you are all familiar with these various conservative methods of treatment. There are a lot of doubt about how long to take bed rest, what kind of bed, should it be in home or should it be in hospital, how strict should be the bed rest, what posture. I think bed rest itself has got very little role in the treatment of, the medical treatment of back pain. Because if the patient cannot walk, he will not walk, she will not walk. You don't have to tell them to go to bed. So you tell them whenever you have severe pain, just lie down. At other times, you get up and be as normally active as possible. The other problem with bed rest is bed rest wrecks the psyche of the person. The person becomes very depressed. They think that this is going to become a chronic illness. They are never going to get up. They are never going to walk. That sort of negative feelings start coming in when you prolong the bed rest for too long. And bed rest makes your muscles waste. So I am against bed rest for most patients with disc prolapse. They have pain, they'll anyway go and lie down themselves. And usually they'll lie down to the sides even without you telling them. Medication is something important. In a very acute pains, you can use injectable analgesics just once or twice, not continuously. You cannot give them injections every day. Then we use the simplest possible analgesics. Paracetamol is our sheet anchor drug. Sometimes we use aceclofenac in patients who have got good gastric tolerance. We also use some of the other drugs. And physical therapies is something which I have not practiced for the last 40 years. And I don't think they have much of a role in treatment. I think you're only humoring the patient by doing physical therapies and waiting for the disease to recover on its own. Even if you didn't do those therapies, the patient, most of the patients with back pain would get better on their own. There are people who swear by traction and say it's the best method of treatment. I have also seen patients who had no neurological deficits, who had traction and who developed cauda syndrome after the traction. So you should be very careful in applying all these other methods of treatment. None of them have really had any proven, scientifically proven effect. So somebody looked at the all the evidence that is there, the evidence-based approach. So there is good evidence for some of the drugs like NSAIDs, antidepressants, but not very good and very good evidence for exercise and very good efficacy also for exercise, and hardly any evidence for tractions, acupuncture, physical therapies, etc. Epidural injections and facet nerve blocks have moderate evidence. So this is the summary statement, which is one of the latest statements comparing non-randomized trials and randomized trials of these various modalities of treatment. It's a very big systematic review that has been done of nearly some 600 odd publications. And this is the conclusion that the authors have come to in this. So I would think that we will not stress too much about the physical therapies. We should go on to definitive therapies. A very important thing is exercise, and this is something that I stress often. I say you have to become mobile. The aim of treatment is not to make you a patient all your life. Take rest all the time. Take rest all the time. I've seen patients taking rest for 3 months, 6 months. Not necessary at all. Maximum 2 days, 3 days, the patient should be up and be about again. And exercise really makes the psychology of the patient much better. It improves the mobility, reduces the backache, and it also prevents future worsening because you're going to have a stronger back with back exercises. Supine flexor, prone extensor, and aerobic exercises are what we recommend for patients with back pain. Now, back care measures. Somebody had asked this question in the before the start of this. What are the things that patients should do? What is the correct posture? There must be a good back support, and while bending down and lifting, it's always better to flex at the knee rather than at the lumbar spine. If you in this position, the lumbar spine is weakest and it gives way. And sleeping to the side is always better. There's a better posture, and this kind of postures are to be completely avoided. Right? They may be relaxing, but they do harm to your back. Now coming to surgery, what are the indications for surgery in our patients? Severe pain, significant neurological deficit, and lack of response to conservative treatment in correlating imaging findings. This significant deficit is there only in about 10% of patients whom we operate. Most of the patients we are operating because they have no response to conservative treatment and they have got a correlating good imaging finding, which tells you that the pain will get better after surgery. The same, if this kind of disc prolapse was not there, this patient did not respond to conservative treatment, we would go on to some other form of conservative treatment. rather than recommend surgery. But because there's a matching lesion in the MRI, we tell them that if you remove this lesion, you'll probably get better. What are the methods that are there? Surgical methods. There is percutaneous transforaminal endoscopic discectomy. There's microlumbar discectomy, which is a sheet anchor treatment, the gold standard treatment, and laminectomy discectomy, which is done for patients who got a lot of canal stenosis, a lot of aged persons with very narrow canals. Now, microlumbar discectomy is done through a very small incision. No bone is removed generally. Patient stays for just 1.5 days in the hospital. They can walk the very next day, and this causes the least amount of back pain to the patient. And this is a kind of an ideal case where you can do a microlumbar discectomy just through a transflaval approach between the two ligaments, between the two laminae. You can get inside and remove this disc. So the incision is very small, usually done under general anesthesia. If the patient is not fit, you can also do it under spinal anesthesia or epidural anesthesia. The microscope is used almost throughout the procedure. And this is the kind of picture that you see at the end. This is the dura, the nerve root. This is a disc space, empty disc space. You can see that the compression has been removed, and that's the magnification at which we are working. We place our patients in either of these two kind of frames or bolsters so that the abdomen is free. There is no epidural venous congestion. We have to localize the level with C-arm. If you don't do that, you are likely to go wrong. And the biggest cause of failed disc surgery is wrong level surgery. And this is the kind of localization image that we do. And when doing this, you should be aware of sacralized L5 and lumbarized S1, which I already talked about. So this is a short video which shows you how this procedure is done. Only exposure is this big, 3 centimeter incision. We have not taken out any bone. The bone is intact over here. There's a lamina above, there's a lamina below. That is the disc bulge. We are just incising the disc bulge now. Are you all able to see the video?
Yes, sir.
Okay.
Yes, sir. Yes, sir.
Yes, sir.
So that is the disc. This is a contained disc which is coming out as one single piece. You can see such a huge mass is there that is causing pressure on the nerve root. You can easily remove this, and with that the job is done. Once you remove this, the root becomes completely lax. It becomes free. Nothing more needs to be done for this patient. This is called fragmentectomy. This patient has got a different problem. Here you see this was the root here, and it was lateral to the root. Look at what happens in this patient. The dural tube is over here, the root is over here. You can see it very clearly. So that is the root which is passing here. And the disc is in between the root and the dura. So this is called as an axillary prolapse. If you look at this at the arm, this is axilla. So it is count into the axilla. You have to be very careful about this, because you can tear the dural tube if you are not careful. And that piece has come out now. Now the remaining part of the disc we don't take out through this small corridor, because the corridor is very small here. You cannot use big instruments like curettes and all that through this. So what we do is we make room lateral to this. You drill off this bone here a little, make room lateral to the root, then approach the disc more laterally. This is a lateral approach to the disc. And from there, we are taking out pieces, more pieces lateral to the root now. This is a conventional root, the lateral root. And look at what has happened in this patient. This is a disc space. The disc is not lying here. It is lying between the body above. It is coming out from that crevice there. This is the vertebral body above. This is a nerve root that is stretched. And you can see the disc coming out there. A huge piece that is there between the vertebral body and the dural tube. That's a big piece. Removal of these pieces is sufficient to give relief of symptoms of the patient. I think I'm running out of time, so I will not go into some of these slides which tell you some examples of our cases, how we made the decision. In this patient, for example, there was a choice. She had taken bed rest. She was not better for 2 weeks. If you wait for longer, will the pain get better? So we give them a choice. You discuss, you can say, you tell them that if you lie down for, if you take rest and walk about minimally, don't strain your back, take some medicines, maybe spontaneously you may get better after another 2 more weeks. The other choice is, if you want to get better tomorrow, have a microlumbar discectomy done. This patient had the microlumbar discectomy and she had an excellent result from this surgery. So generally we say that, let the patient decide first. You give them the choice. Like I said, eclectic approach. Give them the choice, let them make the decision. Young patients, short duration of symptoms, they do very well with microlumbar discectomy. So that's a young patient who's got leg pain more than back pain, Bilateral leg pain, sometimes we do bilateral MLT. Sometimes there are two-level lesions, we take out both discs. And sometimes there are lesions on two different sides, in which case we do only the symptomatic side. Age is not a contraindication. Even old people can have this kind of a disc prolapse. And in spite of the fact that they have some other comorbidities like diabetes, CABG done some time back, they are on clopidogrel, you stop the clopidogrel and then go ahead with the surgery. This patient, we offered surgery, but he did not take up surgery. He returned 4 months later with worsening pain, same deficits. MLT pain done, pain improved, but the deficits persisted. It's a moot question. If he had the surgery earlier, maybe even his deficit would have recovered. So the learning point is that it's a safe surgery even in patients who got risk factors. Delay in surgery means less chance of recovery. So that is the point which I wanted to carry home today. Back pain alone sometimes gets treated by discectomy nicely, but there are also other choices like total disc replacement, instrumented fusion, etc. But this patient did well with just bilateral MLT. So it's a less invasive option. And anytime later, you can also go on for instrumented fusion, etc. Focal canal stenosis is also not a contraindication. This patient has got a very narrow canal laterally here. All we need to do is to just burr off this using the same MLT technique, but no need to take out the disc. Just give enough room for the nerve root. The patient will do very well after surgery. And a person who had a previous surgery, this patient had a laminectomy, 2-level laminectomy done, and had recurrent symptoms due to a big disc over here. So in this patient, there's a big scar in the back. I will find it very difficult to go through the scar. So I made a paraspinous incision, very short incision. Look at the long incision of the previous surgery and the short incision that I have made. And this patient, through the paraspinous approach, I was able to take out the disc microscopically, and the patient had good relief of symptoms. If there is spondylolisthesis, we should be more careful. There's already a slip of the vertebra. These patients typically require an additional instrumented fusion. This is not necessary for all patients who are undergoing discectomy. People ask me, if you remove the disc, what is there for support? When we remove the disc, we remove only the part that has come out and the part that is likely to come out in the future. It's never a total discectomy. So nearly 60-70% of the disc is left behind, which is good enough to do its job. So these are my personal results. Patients stay in the hospital for 1.5 days only. Surgical pain is very mild in most patients. Immediate relief of leg pain is there in most patients. And improvement in neurological deficit occurs in about 3/4 of the patients. And worsening of neurological deficit is a very rare symptom. If you ask patients who have had surgery, let us say after 6 months of waiting, they usually tell us, doctor, if I had known that it was so simple, that it was so complication free, I would have undergone the surgery much earlier. Earlier, people just frightened me saying that you will become paralyzed after surgery, etc. That kind of a thing is not at all true. Permanent disabling deficits are very, very, very rare. It has happened in less than 1% of my cases. And most of these patients already have had deficits before coming to the surgeon. Recurrence rate is also very low. Same level recurrence occurred only in 12% in my series. And adjacent level disease occurred in 6%. And sometimes they have other levels, cervical or even thoracic, etc. That is because of the ongoing degeneration that is there in their bodies. Then we looked at what is called as patient satisfaction in about 500 of our patients. So we scored it on 0 to 10, 0 being not satisfied and 10% being fully satisfied, and various grades in between. So majority of patients were well satisfied with our surgery. Now there is an option called endoscopic discectomy, which is also minimally invasive, but this requires more training and more hands-on experience to be able to carry out successfully. And this is a chart that compares microscopic and endoscopic discectomy. Both are good. You should know how to use it. You should know how to do it. So if that is there, then both these methods of surgery are good. The other thing is, when the studies have been done, they have found that there is no difference in outcome between microscopic discectomy and endoscopic discectomy. In fact, some complications are more common with endoscopic discectomy, some are more common with microscopic discectomy. And recurrences are a little more in endoscopic discectomy because the clearance is a little less, and it takes more time but shorter stay in hospital. These are the results of the various systematic reviews that have been done. So the learning point is, if you're comfortable doing surgery in a particular manner, don't feel compelled to change for something that is new. Something that is new is not necessarily better and may not be better in your hands. So don't feel compelled to change. So finally, summarizing, low back pain is very common. Majority don't have a serious condition. They can be managed at the GP level and at the tertiary care level, primary care level. Persistent pain, neuroscience call for immediate investigations. X-rays and MRI are the choice tests. And surgery must be tailor-made to the pathology, to the age, occupation, etc. of the patient. MLD gives excellent results in young patients with lateral disc collapses. Older patients often have canal stenosis, which also needs to be addressed. Back surgery has undeservedly earned a bad name with doctors and patients alike. The truth is not so. In fact, many doctors who did not refer cases of back pain to me started referring cases after they were treated by me for their own backache. So that is when they develop confidence that, okay, that something really can be done about this disease. So finally, the last slide here. If you have the right patient, if you choose the right patient, if you do the right operation the right way, and if you give right post-operative care, you are bound to end up with a lot of good results for lumbar discs. Thank you very much for your attention. I will take any questions now.
Thank you, RK. It's a wonderful lecture. In fact, lot of our friends told me that this is a very good topic, an ideal topic, and it is useful to all the medical practitioners. Now, Hariharan, can you please take a lot of questions? There are about 350 participants. Can you please take the questions one by one? Dr.Aruljothi, please coordinate. Thank you.
Yes, sir.
I have spoken to the president, secretary, they are traveling, so they will not give any concluding remarks. It is up to Hariharan and Dr. Aruljothi to give the concluding remarks. Wonderful lecture, very useful. Please.
Thank you, sir. I'll stop sharing my screen now.
Okay, thank you, RK.
Okay.
Thank you so much, sir. I think it was enlightening and we learned a lot. I think you have spoken most of the points, but we had those questions in the chat box, so I think it is important that I ask you again. So how long will it take for symptoms like paresthesia in case of lumbar disease, multiple levels, with a conservative line of management to improve?
See, I would think that pain is the one that comes first when you give medicines, rest, or exercises. Pain comes down first. Paresthesia usually takes about 2 to 3 weeks. Even in operated patients, they still have a little bit of paresthesia for a few days or few weeks. So I think if it is persisting for more than 2 or 3 weeks, then you must do something about it. If you have treated the pain conservatively, the paresthesia is still persisting, then, and if it is bothering to the patient, then you need to do something about it. You either need to give a back injection or you need to do surgery or something of that sort. So I would think that 2 to 3 weeks is the time frame up to which you can wait. If there are many patients who had conservative treatment for backache, the backache has got better, but the paresthesia has remained permanently with them. So that is also possible. It depends on how much of nerve damage has already occurred before the patient came to you. Yes, does it answer your question?
Yes, sir. Yes, sir. The next question is, what is the correct posture to prevent lumbar disc prolapse?
Yeah, I had already shown you some of those pictures in my talk about how to sit erect, how to not sit with the slouch, and how to make sure that you draw your chair inside your table on your work table. This is especially important for IT workers who sit there for all the time. And the most important thing is to avoid sitting for long periods of time. Nowadays, we say sitting is the new smoking. We all know that smoking is very harmful. But sitting is as harmful. Not only to your back, to everything, your cardiovascular system, your musculoskeletal system, for everything, it is bad. And therefore, sitting is not recommended for more than 1 hour. So I tell all my patients, even if you're working at a computer job, if you sit for 1 hour, get up and walk about 10 steps, come back and sit down in your chair. That mobility makes your back much better. So important thing is to avoid slouching. Make sure that your chair and table are ergonomically situated. For doctors, I will give you one more clue, especially to avoid neck pain. See, most of the time what happens is patient walks in, you're sitting in a consultation room on a table and a chair. The pain is placed towards one side so that you can easily reach out to them and you can, do the auscultation or do the clinical examination. So you're always turning to one side all the time. So this gives you both back pain as well as neck pain because you're turning to one side. So every 1 month, you change the layout of your table in the chair, put the patient on the other side so that you can turn to the other side the next month. So if you keep doing rotating like this, then you are much less likely to develop backache and neck pain sitting in your outpatient clinic.
Thank you so much, sir. Does calcium supplement help in prevention of disc pathology? This is another question.
No, there is no evidence to say that calcium supplementation prevents disc pathology, but calcium supplementation is vital, especially in the post-menopausal women, to prevent osteoporosis.
Another question.
Osteoporosis by itself can cause some back pain. And therefore it's good to supplement in people who are, you don't go by the calcium values in the blood. You don't go by vitamin D levels in the blood. You go by the clinical situation. Very thin-built persons are usually calcium deficient and they are prone for fractures. Similarly, very obese persons are also prone for fractures, osteoporotic fractures. So in both these conditions, you might think of supplementing calcium. But calcium itself is not used in the treatment of back pain. It does not prevent or treat back pain.
The other
That
one is
lumbar pathology.
lumbar pathology. Yeah. Discectomy with or without prosthetic implant. Pros and cons of both.
Is the question about pedicle screws or about any other implant?
I think it is about pedicle screws. That's what I mean. This
Okay.
is what they have written.
Pedicle
in the
screws
chat.
are used. See, most patients with disc prolapse who are undergoing microlumbar discectomy do not require any form of stabilization because they are anyway stable, and our surgery does not destabilize them any more than what they already have. But if they already have a slip of the vertebra, degenerative spondylolisthesis, in that case, we would, like a example I showed you, where we would put in a pedicle screw and also do a microlumbar discectomy. And sometimes this can be even done just on one side instead of doing it on both sides. The pain is predominantly on one side. There's no, you don't have to feel compelled to put screws on the opposite side at all. One side screw gives enough stability. So one side a screw on the vertebra above, screw on the vertebra below, and then a rod in between, only for patients with established instability. Because in a patient with instability, if you additionally do a discectomy, you are adding to her instability. And that is the reason why we prefer to put pedicle screws up front in these patients. There are a lot of people who put implants inside the disc space, what are called as cages.
Yeah.
These cages are absolutely unnecessary and they only cause more neurological deficits than uninstrumented patients. And they often cause problems because they migrate, they come out, and all those things. So, see, whenever these implants come, in a flush of enthusiasm, all of us surgeons, even I have been guilty of doing that in my younger age. But as you build up experience, you will find that all this is totally useless and you discard all of them. About 15 years back, I used to put a lot of implants in the spine. My implant rate has now come down because I've become more wiser with my experience.
So the next question, which is an interesting question. Can a patient with multiple disc protrusion restart his active sports activity, which involves lots of jumping, bending forwards? And if so, what is the criteria or checklist before restarting his active sports activities?
One thing I should tell you is disc prolapses are usually never multiple. The MRI changes may be multiple, but the clinically symptomatic level is usually one disc. And that is something that we should always remember. Out of 100 patients whom I operate, I do 2-level discectomies on 2 or 3 patients. 97-98% we do just a single level disease, in spite of the fact that they may have some MRI changes at other levels. We select only the symptomatic level and operate on them. So let us assume that this patient has had a surgery for a lumbar disc prolapse or some kind of treatment for lumbar disc prolapse. When can that person resume the active sports activities? For like anything else, like for example, after cardiac surgery, how do you resume activities? You do it in a graded manner. You ask them to first walk out for some time, then you ask them to increase the speed of walking, then you ask them to increase the length by which they walk, and then we ask them to do more active exercises. Once they have done all this, once they have built up their back, generally within about 3 weeks, they are able to return to most of the things they want to do, except for very stressful activities on the back, like weightlifting, gymnastic work, etc. Now, the situation is very different depending on the age of the patient. Young patients usually are able to resume activities sooner and to a fuller degree than older patients. In older patients, you've got to be more careful because they've got more degeneration at other levels also, which you have to be careful about. So it depends. The question depends on how much better the patient has got, whether the patient has got any continuing symptoms or not, and what is the age of the patient. No symptoms, young patient, good muscle tone, you can ask them to come back to their activities faster, usually within 3 to 4 weeks. For some other contact sports which involve a lot of jumping and all that, we ask them to wait for about 3 months. Whereas in an older person, we'll put some restrictions here and there for some of these extreme activities, not for routine activities. Routine activities should never be restricted in a patient with a back pain. It is the extreme activity that needs to be sometimes restricted and for periods of time. What about patients who had fusion surgery? They can resume their activities faster because their spines are stable. They are painless. Therefore, as soon as the wound pain subsides, within about, let us say, 1.5 months to 2 months, they can start resuming most of their activities.
Like Angst spondylitis, and there's a link between HLA and Angst spondylitis. Is there a link between HLA and lumbar disc prolapse, sir?
There's a lot of genetic studies that are going on. It will become another separate topic to talk about it all. And most of it will be even going over my head, because even though I've been in this field, I've been talking and writing about it. A lot of this genetic terminology is something that we cannot easily understand as doctors who have studied, let us say, 50 years back. And so about HLA itself, there is no specific information that I have at the moment. I can check it out and let you know. If you give me your mail ID or something, I can let you know some articles that are there about it. Right now, I don't have that information, but I won't be surprised if this disease turns out to be predominantly determined by genetic factors, because more and more the world is coming to the view that a person, there are two people who do the same kind of activities. One person develops, one person does not develop. They have done things like homozygous twin studies who have totally different lifestyles. One person is leading a very active lifestyle, one person is leading a very sedentary lifestyle. Both of them have the degeneration of the disc at the same rate. So that means there is some genetic factors which we don't still understand fully, which are responsible for the causation of the disease. That is why when...
Sir, one more academic question, sir.
Yes, please.
Sir, regarding stem cell therapy, role of stem cell therapy in lumbar disc prolapse chronic.
No proof.
Anything, sir?
No proof so far. No proof so far, sir.
Thank you, sir. One more question. Is
Yeah.
there any hormonal impact? Is there any difference between whether men or women can get lumbar disc disease?
Actually, the disc prolapse does not distinguish between the genders of the persons. Both men and women do suffer, but the changes progress just in relation to age.
What way
There are
help?
certain factors in women, they do less physical work. Pardon?
No, sir. Please continue, sir. I thought you had finished your answer. Please continue, sir.
Okay. So women are generally physically less active, and therefore their muscle tone, everything is less. So their suffering is more. In fact, in many patients, many places, you would have noticed that I said his, and in some places I said her. Her is actually more common. Women have more degeneration in their lumbar spines. Also, they have more osteoporosis. And when they have more osteoporosis, they tend to become symptomatic faster. So for all these reasons, though we see it in both sexes, women have a slightly higher tendency to have disc degeneration.
More so with the postmenopausal women, sir.
Yes, true. Very true. You're right.
What way can physiotherapy help in lumbar disease?
I think the benefits of physiotherapy mostly are psychological. And secondly, it is physical.
Is there any time
psychological
limit?
Because you tend to get feeling. No, I'll tell you. I'll let me complete. Psychological because you have a feeling that you have a handle on the whole thing, that you can control it. It is up to you to do it. And so when the person becomes correctly motivated and when he starts following a rigorous program of exercise and physical therapy, the patient definitely feels better. So I think it is the feeling of that feeling good that happens out of physiotherapy, which is the most important cause. Of course, there is some reduction of pain, definitely. If you take an ultrasound massage or if you take a shortwave diathermy or something, there will be some amount of relief. The relief will be a little more than what you get when you pour hot water or when you give an ice pack to the person. So that relief of pain, again, makes the patient feel better. The patient psychology improves that way. The other thing that happens is with all physiotherapy, especially the active ones, the exercise kind of physiotherapies, is that it builds up muscle tone. It prevents the cycle of pain. What is the cycle of pain? Once the patient gets a pain, there is spasm of back muscles. The spasm causes more pain. The more pain causes more spasm. So this keeps on going like a vicious cycle. Physiotherapy breaks that cycle. So that even if the pain has got, the pathology is still there, the pain is not felt. And that is the advantage of having physical therapy. But all this is only surmises. There is no evidence, like I say, randomized trial. That kind of evidence is not there for any of these methods of treatment.
Is there any time limit for recovery from lumbar disc prolapse? I think conservative. I think they're meaning
the patient.
Yeah, I think that
depends on the waiting capacity of the patient. But as a doctor, if you are treating a patient who's got just a disc collapse, with symptoms and no neurological deficits, I think you should review the patient every 2 weeks. They should be on a graph of improvement. If they are already on a graph of improvement, if the pain is, let us say, first day it is 100%, when they come to you it is about 90%, and after the first 2 weeks it has come down to about 40%, then he's going on the right tracks. You can wait for a little longer period of time. But when the pain is not getting better, or if the pain is getting worse over time, then you need not wait. Generally, I tell my patients, you wait for 2 weeks. If you don't get better in 2 weeks, your chance of getting better in 2 months is much less. Your chance of getting better even in 2 years is much less. So after 2 weeks, you have to take some kind of a decision about the patient's treatment. Something more definitive has to be done. So generally, I would say 2 weeks. But in a person who's not very disabled, in a person who's got only a mild degree of pain, in a person who's got no neurological deficits, a person who doesn't put much demand on his back, you can afford to wait for another 2 or 3 more weeks for the pain to get better. And generally, by waiting, most pains go away.
Does collagen powder intake help disc nutrition?
No, not at all. Collagen is broken down in your stomach. Collagen is a large protein. It is broken down in your stomach. It never reaches as collagen into your tissues.
Can the patient ride two-wheeler after MLD?
Certainly, after a period of waiting and during which time he does exercise, does other activity. That's why I said it's graded. So when we discharge the patient, we give them a list. In so many days, you start walking. In so many days, you can start doing this. In so many days, you can start doing these activities. In 2 weeks, you can start riding bikes. In 3 weeks, you can bend down and start lifting weights. So like this, we write down everything and give it to the patient. So everything has to go by stages. You can't say that you'll have MLD today and you will ride a bicycle tomorrow. That's not the kind of you need to put the back through a rehabilitation program, and that rehabilitation program usually lasts about 3 to 6 weeks.
Role of steroids in
In what?
Role of steroids in disc compression, sir.
Okay, when the pain has got an acute severe pain and the pain does not have any deficits, if you give oral prednisolone, the pain will definitely get better because there is an inflammatory component to that acute pain, and that inflammatory component settle down. But this should not be given for more than 10 to 15 days. It cannot be a long effects on the bone, adverse effects on the disc, and therefore we don't give it on a long-term basis. Very short course of treatment you can give in a person who wants to wait anyway. Then there is another form of therapy which is given locally inside the back, either epidurally or into the facet joints or into the disc itself. That has got some benefit, and I told you the benefit is moderate, and the proof for it is also moderate. So there are 2 forms of steroid therapy. Both of these can be used. All these are done in patients who don't have neurological deficits. The patient has got neurological deficits, you should be considering something more than just giving oral steroids.
What is the management for chronic back pain without sciatica?
It depends on what is the etiology of the chronic back pain. See, the chronic back pain, if it is due to spondylolisthesis, it has to be managed generally by surgery, because if bracing and all that does not help, you have to do surgery for it. Whereas if it is just due to a degenerated black disc, then you may put the person through a longer trial of conservative treatments, which I mentioned. And when they don't help, you can give them back injections. If that also doesn't help, then you can finally do surgery for them. So how much you wait depends upon what is the disease that is there in the patient based on his MRI and based on his flexion extension X-ray. This is one thing that I want to tell you. X-rays that are taken in the lying down position, MRI that is taken in the lying down position often misses spondylolisthesis. Spondylolisthesis is seen sometimes only when the patient is made to stand erect and an X-ray is taken, or when the patient actually flexes the trunk and extends the trunk, then you will start seeing the mobility. And many patients who got chronic back pain who did not get better with any form of therapy, including bracing, back injections and all that, they have come to me with an MRI which shows hardly any pathology. They don't see the spondylolisthesis on the MRI, but the moment you do the flexion and extension X-ray, you see the obvious pathology over there. You stop that immobility, that instability over there, immediately the patient becomes better. So it all depends on what the pathology is for chronic back pain. If the patient just has got multiple level discs then these are the kind of patients who are really troublesome to the doctor because they never get better. Many of them really get better with amitriptyline and with escitalopram and antidepressant drugs. There is good evidence to say that antidepressant drugs work well in these patients.
Does lumbar belt help in this disease
Pardon?
without any fracture? Does lumbar belt, sir, the belt?
Okay. I don't use belts. I don't use traction. I don't use any of those traditional forms of therapy. In fact, most patients are very happy because I give them liberation once they come to me. I tell them, throw away this belt, throw away this traction set that you bought, throw away everything, start moving about, start walking from tomorrow. That confidence that I give them makes them a different person when they go out of my clinic. And I think that is the most important thing that I've learned, that backs don't require rest. They require to be moved. It's a moving organ. What happens to your car if you leave it alone and don't switch on the engine for 1 month? Definitely it'll go bad. Instead, if you take the engine out, if you take the car out and drive it every day, it remains in shape. Your body is exactly like that. So please remember that it is mobility that is important, not just rest.
Will this prolapse cause early morning back stiffness? Should they lie on the floor instead of the bed?
It all depends on how the patient feels. Many patients ask me this question, should I lie down on the floor? Should I lie down on the bed? I say, what have you tried? Have you tried lying down on the bed? Have you tried lying down? Before coming to us, they had already tried all this. So somebody says, I get a very bad backache when I lie down on a bed. I will say, you change the bed or you lie down on the floor because that patient needs a good firm back support. Most beds, after some time, see, most people buy the beds at the time of the wedding and they don't change it for 10 years. If it is so, it would have taken a particular shape and it would not conform to your body shape at all when you lie down. And then you get a lot of back pain. If you buy a new bed, the back pain will disappear. It all depends on what they feel comfortable with. I tell them, you try out whichever you are comfortable with, you do it. There's no contraindication to lying down on the floor.
Do you follow any specific management for end plate changes? As it causes
They are just a phenomenon that are seen on the MRI. They may not have much of clinical correlation. We go by the disablement of the patient. If the patient has got an incidental change that is seen in the MRI, like I have done an MRI of my lumbar spine, I have never had backache in my life, thank God, touch wood. But there is a lot of end plate changes that are there in 2 discs for me. But nothing has happened. So it's not something that has a clinical correlate. You will see another patient who's got only 1 level disease and got severe pain. Such patients will need a fusion surgery, not just a discectomy.
Any role for vitamin B for lumbar disc?
I don't think so. B1, B6, B12, I don't think they've got any proven role. They're all commonly given, but I think they're of no use in these patients. In fact, many patients keep taking injections, every week once, and they feel much better. I think most of them are having only a placebo effect.
Can there be a re-herniation after MLD?
Yes, I showed you my percentage. There were 12% of patients who had a recurrent disc collapse at the same level. It is possible because you're leaving a hole in the disc and some more degeneration occurs, some more material and you never remove the disc material fully. You only remove what is causing the symptom and what is likely to cause the symptoms in the future. But in spite of that, sometimes a big piece gets detached, some unusual strain or something like that, and then they can get a recurrence. 12% of my patients have had recurrence.
Does laminectomy and discectomy need post-stabilization? What about laminectomy and discectomy with stabilization?
Again, the answer depends on the amount of instabilization that is caused by the surgical procedure and by the degenerative disease. If you're going to remove a lot of the facets, then I think it's better that the patient undergoes a simultaneous fusion. Whereas if you're just doing a laminectomy and just a little bit of de-roofing of the lateral canals by doing a mesial fascectomy alone, micromesial fascectomy, then generally the patients are not unstable. They don't require a fusion. Similarly, it also depends on the kind of occupation the patient is doing. Like, for example, an IT worker who has lumbar laminectomy, he need not necessarily have a fusion done. But if the same person is going to a coolie, for example, who lifts weights, he will probably need fusion because he's going to throw more stress on his back. So the question is a very complex question, and all these things have to be considered to decide whether the person needs a fusion or not.
Travel and disc prolapse, how common is it? Does it
It
worsen?
is fairly common. See, the other problem is we always try to find a cause. We try to blame something or the other. So most patients have told me that, see, I have been travel. It also depends on whether you travel for pleasure or whether you travel under pressure. There are two different things: traveling for pleasure and traveling under pressure. Like for example, most of the sales people, they are traveling really under pressure. I mean, not just the physical pressure, the psychological pressure that is there on them. Those patients invariably feel that if they stop driving, they'll get better. But that's not really true. I think it's more to do with the condition of the roads rather than the back itself. The roads become better, probably driving will become easier, and the backaches will become less. It also depends on the way in which you sit in your scooter or in your car and drive. Some people have proper supports; they sit upright and they drive the car. They don't have pain. Whereas some people really slouch forward, put the seat back too far backward, lean backwards, and drive the car. Such patients may develop pain. So it's again a very complex question. You cannot say yes, it causes, yes, it does not cause. That way you cannot answer. It depends on so many factors, especially the condition of the car and condition of the road.
So what is the approximate cost of endoscopic surgery for this prolapse?
It depends on the hospital and the ward of the patient. The least cost in a general ward would come to around 1.5 lakhs.
And also comorbid conditions, yeah, comorbid also.
That's naturally there. You're right. You're very right. If you have to treat diabetes, hypertension for 2 days extra, 2 more days of hospitalization, so many more investigations. So those things also matter. But I'm talking about the simple, uncomplicated case.
Yeah.
Sir, to sum up the last question, sir, what is the best way to prevent this prolapse?
The future tells the answer. We don't have an answer as yet. But one thing I can surely tell you, rather than being sedentary, if you're active, moderate levels of activity, that will prevent not only back problems, it will prevent so many other diseases. And I think that is the only mantra that we need to know. Be physically active. Don't become couch potatoes.
Thank you so much, sir. I think it was wonderful hearing to you and learning a lot from you. It shows the vast experience you have. And thank you for all the time that you have spent and shared your knowledge.
Thank you so much. It has been a very nice interaction. And I've never had so many questions in any one session. And that shows the amount of interest that is there in this topic. Very nice of you to have chosen this topic.
Thank you, RK. RK, we are planning to compile into a book all the lectures for the benefit of the youngsters who are joining.
Sure.
You can even incorporate the questions also in the form of a lecture.
Sure.
And please give me. Thank you, RK. So nice of you all.
Thank you so much, sir.
Thank you.
Thank you.
Thank you.
Thank you, Ashraf, sir, for the opportunity.
Thank you, Hariharan. Thank you, Aruljothi. Thank you so much. Aruljothi, please give the vote of thanks. Aruljothi?
Sir, you are muted.
Sorry, sir. Sir, thanks a lot, sir. We immensely thank Ramakrishnan sir for giving comprehensive and knowledge-packed lecture, sir. And thanks a lot to moderator Dr. Hariharan sir for moderating the session. My special thanks to all the participants, because making the event successful is mainly depends upon how many participants participates and how they interact with the speakers. We planned in a structured way. We received questions in advance. Thanks for registering in advance, so that we had a good discussion with sir. This time we will send you the link with the permission of the speaker. We will send you YouTube link to your email, so that you can watch it leisurely again if you want. As well as we are planning to have book at the end of this year. We will do that also. Thank you, sir. Thank you very much. Dear participant, please do type your name, TNMC number, email ID in the TNMC number, email ID, and mobile number in the chat box. If you have done already, no need to do it again. Thank you very much. With this, we are closing this. And sir, Ashraf sir, are you there, sir? I just want to thank a few more people. Sir, I want to introduce our IMA TNSB Academic Committee members: Dr. Abdul Zaziz, Dr. D. Sendil Kumar sir, Dr. G. Mugundan, Dr. Hari Vishnu, Dr. K. Sundaramurthy, Dr. V. Sugavanam, Dr. Saravanan and Dr. Ramakrishnan, Dr. Karthik Bandari and Dr. Ramakrishnan. We are working as a team in this academic committee. Thank you all. Thanks to all academic committee members as well as Dr. Praveen, TNMC observer, for coordinating these events details to the TNMC office. Thank you. With this, I am signing off. Thank you. Thank you very much.
Thank you so much.
Thank you, sir.